Let's get into this with our, I was going to say panel of experts, and of course they are experts, having experienced healthcare from many different angles. And Frida, as you watched that video, what sprung to mind for you?
Well,
and pull the microphones nice and close, everybody, when you speak, okay?
actually, I can relate to that. When Nick was still at home with me, he had an accident, fell over the front of his walker, and cut his nose and banged his head. And so I thought that warranted a visit to the hospital. We arrived at the hospital, and I explained what had happened. And we went through, I think it's triage, and they took his blood pressure and whatnot. And they said, you can wait in the waiting room. So we waited, and a little while, maybe an hour and a half later, we went through the big door to the back. And we sat and we waited and we waited and we waited. And a nurse came in and, talked to us a little bit. And then finally this lady came in, and she had a white lab coat on, and she said, "Oh, Mr. Fergassi, are you here because you have a headache?" And I said, I spoke for him, being his advocate. And I said, actually, no. He had an accident at home. He fell over his walker. He has a cut on his nose and has banged his head. And he has dementia, and so this is why I'm speaking for him. So she kind of looked at his eyes and looked at the little cut on his nose and said, "Oh, I think you're going to be fine. Just maybe watch him for 24 hours. So she was about to leave, and I couldn't help myself. I said, "By the way, I didn't get your name." And she said, "Oh, I'm Dr. So-and-so." And I said, "Well, that's really nice, because I thought maybe you were the cleaning help." I didn't know who I was talking to, and that was our experience.
That was your experience. What was your expectation, though? If things had gone the way you wanted them to, how would it have been different?
Well, possibly she could have introduced herself, first of all, and said who she was, and maybe taken a bit of interest in the form of dementia that Nick had. Having PSP, it does affect your eye movements, and his eyes do not go up and down. So I don't know what she saw when she was checking his eyes because of this bump on his head. So.
Mary Ellen, I don't know if you can hold the mic, but if not, maybe Frida could.
She has one.
Oh, you have one on? Oh, that's perfect. Yes. Okay. Let me get your impressions of the video that you just saw.
Actually, I had a little bit of difficulty seeing it. At this point, I'm not so sure that I have a reaction, except that sometimes it's hard to have a conversation to explain exactly the situation, and it seems to me that that was her situation too, to even get the first line, what happened, and to get a proper opinion.
You said it's difficult to get that going. What makes it difficult when you're in that circumstance?
I think if there are a large number of people waiting, there's always a rushing. And the other thing is just getting the attention.
I'm going to infer from that, Paul, that it's not necessarily anger with the people who are in the healthcare system, but actually, at least I've noticed along the way, that some people are very sympathetic. Patients are sometimes sympathetic to the people who work in the system. They appreciate the stress they're under. They appreciate how resources are stretched and it's a difficult thing to do. But having said that, they want more. They want better treatment. Is that understandable as far as you're concerned?
Very much so. And it's not uncommon to look at patient comments on surveys where they will, in fact, acknowledge from their perspective that the nursing staff or whatever staff are attending to them are stretched, and that may be a rationale for why they didn't get the attention that they might have wanted. So I think, yes, there are many people who are very sympathetic to that. On the other hand, from the perspective of the provider then, there's a certain necessity to put in place sort of an emotional labor, if I can use that term, where regardless of the circumstance, there is an expectation that somebody who has that duty, that sort of noble duty to be in another person's life for that instant of care, to step up regardless of the circumstance and recognize what expectations the individual on the receiving end of the care has, and to be sensitive to that as well. So yeah, I think there is amongst many, there is this sympathetic component, and that sometimes where they are very understanding that these providers are under a lot of pressure. But that doesn't change necessarily in the end their expectation.
We saw near the beginning of that video, the patient looked up at the wall, saw that sign, and could not make head nor tail of it, and I don't blame them. I've been in similar circumstances looking for an MRI or an ultrasound, and you look at that just layer after layer after. Tell me you don't have any signs like that in your hospital.
We do have signs like that in our hospital. You know, we've done some work to make these signs, you know, following the accessibility standards for Ontario. But I will tell you that every day, Frida and I were talking about this sitting at the table. Frida said, you know, you guys call it diagnostic imaging. The rest of the world calls it X-ray. And why isn't that utilized on that? You know, there's the basic jargon stuff.
So what's the answer to that?
I think the answer is understanding personally from the non-provider perspective what actually makes sense, and secondly, making those signs, you know, in a way that is easily readable, easily understandable, in the right size of font. We have signs that have maybe 30 items on them. And you know, the first task of anybody is to try and find the item that they're looking for, and then hope that that gives them some direction. Daily, and I bet everybody in this room has experienced this, when you walk into the hospital, I will pass by somebody who's staring at a sign. And you know, my inclination, of course, is to stop, and I think a lot of the staff of the hospital, that's their inclination, is to stop and ask if they can help folks. So it's not intuitive.
Sue, when you saw that video, what sprung to mind?
Oh,
Pull the mic nice and close if you can.
okay, thank you. Just that it's true. It's way too true. You know, either as a caregiver for family members, as I've been helping them navigate the system because I'm the insider, right? And so often get taken along to be able to help family members when they head to hospital. It just is so true. And we, I think as I've interviewed clients, and some of our team have interviewed clients who have gone home from hospital, the stories that they tell about having to transition. So it's when you're entering the hospital or when you're leaving the hospital that makes or has the most anxiety producing, and it's really about understanding what's happening, both from a signage point of view, but also from what's going on with me, if I'm the actual patient, and someone that can tell me in plain language, and it has to be plain language, about what's going on with my care.
If the people who run our healthcare system know it's true, and the patients who experience it know it's true, how come we're not making fast enough progress on fixing this?
Because it's not easy. It is really a very complicated system, and we have expectations as clients, as patients, as people. We have expectations as a system, and so I think this is all about us, and that's why we're working on this. Is to really get together and think this through. One of the things that I think will help us is listening, and not only listening to hear, but listening to learn, because people like Frida and Mary Ellen, it's about making sure that when they tell a story, that we ask them more and more questions and dig deeper so that we can truly learn from them.
Frida, when you have an experience, an encounter with a hospital or a community health clinic or primary care, whatever, how well do you think the person you're dealing with, who's the healthcare professional, listens?
I think for the most part, they do listen. They do listen. I'm not just too sure how to answer the question, other than that I haven't really had any other encounters where I've ran into that they haven't listened or they haven't been communicative that I
Well, the
haven't-
first example you gave suggested that there wasn't a lot of attention or listening happening.
That is true in that situation, yeah, yeah.
Is that an anomaly, or does that happen more often than you wish?
I think it's an anomaly. Yeah, I think so.
Marilyn, do you want to come in on that as well? How well does the healthcare system listen when you need help?
For the most part, I feel that they have listened, and it's sometimes exactly how you get there. And I live alone and had nobody advocating for me at that time. So I was speaking for myself always. And when you're uncomfortable, you tend to come off in a very different way.
Paul, I'd like you to follow up on that, because everything I've read about healthcare says you need a champion in there with you, advocating on your behalf, because if you're sick, if you're stressed, if you're obviously not in the best condition because you're in a hospital to begin with, it's not good.
Mm-hmm. Yeah, and I think that's probably a reality, but in a way, it's a bit of a sad reality. I think you asked the question about, so if everybody kind of agrees on this, why aren't we further down the track? And I think, to be honest, I think healthcare has come late to this particular point where we're talking about experience as starting to elevate its importance in the world of healthcare, in the world of hospital care in particular. For a long time, our culture has been one of doing for, as opposed to doing with, and it's a difficult thing to change. But the advocate would not be nearly as necessary if we were enabling people who actually provide and deliver that care to be critical thinkers, to be able to assess from a kind of a patient-driven perspective what the needs were, understand those expectations, create the time to be able to do that and to measure that and to provide incentives for that, as opposed to maybe some of the disincentives we have now that keep people away from or take them away from those important conversations, where there would be less need for that advocacy because the system itself and the people in it. At the end of the day, we talk about a system, but the system is about an interaction between two people often, and how do we ensure that interaction is the kind that that creates a sensitivity to the need of the patient, to the expectation, and then allows the individual to go ahead and deliver on that. We have a lot of restraints that don't create that kind of environment.
I should follow up with Frida on this, because, of course, your husband cannot go get care on his own, I presume.
No.
You've got to be with him all the time, right?
Absolutely,
So
yes.
you're his champion. That puts a lot of pressure on you to kind of be on your game every time you have an interaction with the healthcare system, right?
Yes, yes.
Do you find that difficult?
In some cases, yes. We've just been transitioned into long-term care. And Nick faces many, many challenges every day. But as it happened, when he transitioned into long-term care, he developed angioedema.
What's that?
It's a swelling. It's like I'm not a doctor, so I won't. But probably an allergic reaction, but we weren't sure. And he was taken to Strathroy Hospital. By the time I got there, his tongue had rolled into the back of his throat, and he was really having trouble breathing. Mind you, keep in mind, with PSP, the tongue is very thick and rigid to start with, so that made it even more difficult. By the time I got there, he was thrashing around and really, really having a hard time breathing. So, we decided that he had to be intubated with a breathing tube. And at that point, we transferred him over to Victoria Hospital in London in critical care, where he was very well looked after and was observed for maybe 7 days. Then transferred back to Strathroy Hospital in a step-down unit, Friday evening, we brought him back home, and he began to bleed profusely, thick red blood, so back to emerge in London, and he was severely dehydrated. Once they got fluids on board, he started eating and, drinking somewhat. Back to Strathmere Lodge, where a week later, the same thing happened again. Not as bad, because the doctors in London had suggested they put him on like a steroid as well as the Benadryl and epinephrine that they were giving him. And again, we talked about intubation. And as a family, we got together and decided that it was a benefit for the moment, and it was a treatment, but it was not going to change Nick's disease that he had. It wasn't going to make any difference. It wasn't going to improve the disease. It wasn't going to help the disease. It would just be for that particular time. However, at this time, the medications did reverse it, and it did. He was fine, and he's back in long-term care. But again, the transition has been really, really hard for him. I do have to advocate, and that's why I'm here today, because I want people to know about all the services that are out there for people like Nick and others who Mary Ellen too, all the people. We have to make the public aware of all the services that are out there. The reason that I was able to keep Nick home for 5 years with me was because of the services that are out there. He attended an adult day program 3 times a week, which gave me some free time. Very, very good for him, very stimulating, and it was excellent program. And then we moved into Trillium Village, where we fell under the guise of supportive housing, which again, it was run by the VON. They're in the building from 7 in the morning till 11 at night. So we have care daily. We were still getting our visits, plus walks for Nick. I was getting more respite help, so that allowed me to do things that I wanted to do. But still, at the end of the day, you're still there 24/7. And that's when it just got to be more than I could handle. And we signed the papers. And before we got the call that we had to be there on a certain date. And he looked at me and he said, "Frida, do I really have to go?" And I said, "Nick, it's not because I want you to go. It's because I can't look after you anymore. I'm not able to do it myself and with help. You need more help than I can give you. So we have to do this." So then when all of this other stuff happened, it's really been tough. It's really been difficult. But he's in a good, safe place. I'm very impressed with the long-term care Strathmere Lodge where he is. They've gone above and beyond, and I can't say enough good things about them.
You're really quite heroic, you know that, eh?
Oh.
I think that, yes indeed. Okay, the question then goes on. I have to thank you for sharing all of that. I know it's very personal information, but it's, I think, very helpful to our understanding of the issue that we're talking about here today. Sue, the question I would follow up with for you is, Frida and her family have obviously had a lot of interactions with the healthcare system, and for the most part, it sounds like it's been constructive. How representative is she of those who have frequent interaction with healthcare?
Well, I think Frida's story is, all stories have both positive and things that we can improve on. And so Frida, as she tells her story, I start thinking about, well, we could have maybe helped a little bit more there or a little bit more in that particular transition. So I think for most of people who interact with the healthcare system, at the end of the day, there's more positive than negative. But for me, it's about understanding those those pieces where along that journey, what could we have done a little bit differently that could have helped certainly Frida not have to be maybe quite so heroic every day, because it's tiring over a very long period of time. And so I would go back to those little pieces, because they're not big pieces always, that we could improve on along that journey. And I would say that it's around the emotional pieces of that journey are often the spots where we could support better.
I was going to ask that, actually. Do you have people on staff whose job it is simply to try to cheer people up or deal with their grief, less from a medical point of view and more from just an emotional connection point of view?
I think that all healthcare providers have a piece of what they do and expect, and certainly as a nurse, I would expect nurses, I would expect other healthcare professionals to have a piece of their work that pays attention to the emotion piece. One of the people that we interviewed who's in assisted living in one of the small towns in southern Ontario here, and for her, yes, she needed the physical care morning and night to help her get up in the morning and to get ready for bed. But the important thing for her was that there was somebody there to say goodnight to her. And so there was a whole emotional piece for her that made a real difference, and that connection to the PSW who was providing that care.
Paul, the follow-up for you then becomes, is there anything specifically you can point to that you've changed about the way your hospital does business as a result of having heard specifics about the patient experience there? And if so, what?
Yes, I think there's multiple things. I can give you some examples, just personal examples of, in the last year, we've started doing patient rounds. So I have a regimen of rounding in the hospital and speaking to patients directly. I follow sort of a similar questioning of each patient around their experience, very much experience-centric. And that has really been an eye-opening process. It gives me quite a different perspective than I had before. And the reason that we've gone to this particular mode, which I think many hospitals are embracing, is for that reason, is to be able to learn directly the impact of the staffing model, the various models of healthcare that you're putting in place. I had a contact with a lady just on Tuesday who had called up, and she was with her husband in the hospital. Her husband was admitted to the hospital in November with cancer, a quite painful form of cancer. And he subsequently died in the hospital 2 weeks later. And she phoned me, and her opening remarks were, you visited us when we were in the hospital, and you said that if we had a concern, we could talk to you about it. And she said, that's why.
You meaning you personally?
Me, yeah. She said, we could talk to you. She said, I'm phoning you 6 months later, and the reason is because I've been grieving, and I wanted to make sure my perspective was correct on this particular issue. She then described her experience as being very good. She talked about the nursing staff, she talked about the physicians, she talked about everybody. And this was a woman who was a retired nurse. So she knew of what she spoke, and she was very articulate. But then she mentioned this incident that occurred between her husband and a nurse. And it was, I won't go into the details, but from her perspective, this was one that did not show compassion. It did not live up to the value. But it was interesting for me because even though, and the outcome, I mean, her husband passed away, they expected that. So obviously outcomes and experience, I think, meet at the expectation, sharp end. And she initially was talking about her experience in very positive terms, but then got down to the nut. The thing that had really been irritating her and her entire family was this very simple interaction that probably was about 2.5 minutes long between a nurse and her husband and her son who was there and herself. And it had been bothering her so much that she felt she had to make contact. When I asked her, so what would you like to see done? She said, well, I don't want that to happen to anybody else. And so I've been able to follow up with one of our wonderful nurse managers in the organization to say, let's have a discussion and see what we can do about this, because what that interaction was about a value that was compassion, that this individual didn't see. You can only see a value through behavior, and it wasn't there. So it's a great learning for me about this experience business. It was this 1-2 minute interaction that she has carried with her for 6 months and felt such she was compelled to talk to me personally about it.
Mary Ellen, do you find in your interactions with the healthcare system there's enough compassion there when people deal with you?
Yes, I have. I have found that they have listened very well. And this past year has been especially an onerous time because I was in hospital 4 different times, and different hospitals, and have found that they equally try to make me feel comfortable, and were there always when I needed. And outside of maybe 1 or 2 bad experiences, the rest was really very positive.
That's good to hear. What made the bad experiences bad?
It was just because I had acquired a hospital infection and required returning to the hospital to follow it up. I had said that I wasn't leaving until it was gone, the infection. And one of the first visits in my personal care with a nurse was that she needed to change gloves, and she didn't, and I reminded her, and that
How did she take to the
changed
reminding?
things. Pardon?
When you reminded her, how did she react to that?
She was quite taken aback. She was fairly efficient, and it was just in haste. She was hurrying, and at any rate, I met with no further kinds of happenings.
Was she a bit ticked off at you, though, for telling her?
No, she wasn't, but I think it made her a little wary of coming back. I didn't see her anymore in my room.
Now, you mentioned before that at the beginning you used to make these hospital visits yourself. You didn't have a champion
Yes,
to go in
I
with
did,
you.
because my son, although he's in Burlington, he was as close as a phone call, and came when he could and when needed. I have a daughter in London who is a very young family, and she also has a career. And it just so happened that all of these incidents where I needed to be hospitalized happened at night. So it's not easy to particularly get somebody up, and I guess I just declined to bother them.
So who's your
at that
champion
point. Pardon?
when your kids are not available? Who's your champion that helps you through all this?
I guess myself. I'm a very independent person, maybe to my own detriment at times, but the system, just relying on the care, and it is excellent, I have to say.
Good to hear. Sue, having heard the stories this morning, and of course, based on your own personal knowledge of how things work, where do you think the greatest opportunities to improve patient care, or as I guess you folks like to call it, client experience, where are those opportunities?
Well, I've done a lot of thinking about that over the last little while because it's really important in the work that I'm currently doing, or maybe it's a luxury in the work that I'm currently doing that I have an opportunity to spend time thinking about it. And I think for those of us who are care providers, it's about us paying attention to that emotional side. You watch the video, it's about introducing yourself, it's about spending time. We know that those negative experiences, as we've just said, are often 30 seconds or 2 minutes of all of our time that we spend with patients and clients and residents. And so for me, it's about us as caregivers really being open and respectful and taking the time. And if you actually do those time studies, it takes no more time to introduce yourself and spend that extra little space listening than it does to, in the video, the gentleman who stomped back and forth a couple of times, I mean, he could have introduced himself and actually said something polite during that period of time, and it wouldn't have taken any more time. So it is about us, I think, really spending some time thinking about doing things differently. And one of my thoughts is to really work with the educational system to actually help as people become new caregivers in the system, that they learn that and it becomes part of the culture.
Paul, how would you answer that one?
I would agree with Sue. I think there's a number of things that are changing out there that are taking what healthcare does really well, which is sort of scientific evidence-based approaches to here is the safe way to deliver a medication at step 1, step 2, step 3. Here's the safe way to do an operating procedure, and to start to use that method and apply it to the relationship piece. For example, a nursing shift handoff in a hospital at the bedside with the patient, as opposed to at the desk with a chart. That the patient is included and their family member is included in hearing what the transfer of information is and is able to add in information that they think is important. But that this isn't a nice to do. We can script this and we can make this a fundamental part of the process of caregiving, as well as sitting with that patient eyeball to eyeball and asking them about what's the most important thing that they believe they would like to have done that day. And sometimes it's not that the medication gets delivered, or that it can be the visitation of a family member who's coming. It can be many different things. The idea of putting a whiteboard on the wall at the patient's bedside so that the staff can write their name down in a font that's big enough for the patient to see, so that they know their name, they know who they are. That there is regular rounding, so that patients are not always at the mercy of a call bell. There's lots of things at the bedside, at the actual point of care, that many of our frontline staff and that this is what they do normally. They do this all the time. The problem is that we don't have the consistency there, and that's what we need to build in. We need to start putting these steps in that ensure that happens. That doesn't substitute for the personality and the sensitivity of the individual, but it goes a long way to ensuring that the experience becomes paramount.
Okay, that's at the bedside level, but let me revisit the question from a more systemic level. We had the Deputy Minister here this morning. I think the Health Minister's coming to the conference as well to address you. What steps could they do? What overarching steps, Sue, to you first, could they take to improve on some of the things we're talking about today?
It's a tough question. I think just off the top of my head, it is about balancing. I think Saad said earlier about balancing between the cost and the actual person. And I think it's about making sure that the person's voice is heard in every decision. And so that could be in writing reports. I mean, if you go through the reports that are available within the ministry or even within some of the LHINs, there's not necessarily a patient voice or a patient story in each one of those reports. And so it's really about bringing that voice and thinking that through with every decision that you make.
Paul, at the overarching level?
Yeah, I think what Sue has said is important. This has to, this burgeoning interest in patient experience can't just happen at the bedside or at the handoffs of care or in the home. I mean, that's where the rubber meets the road. That's the sharp end. But we have to have all of the policies in play, the incentives. The ministry supports patient satisfaction surveys at this point, and we'll continue to do that. But we probably have to get better at obtaining patient information in a broader sense, so that we can understand needs better, can understand what sort of things you put in play that actually enhance the system, enhance the experience consistently across the system. And I think there's a role for for the minister, for the ministry, for the LHIN to play in policy setting and establishing incentives for change in this area.
Frida, let me bring you in at this point, because we've heard the obligations on the professionals on how they can make things better. And I want to find out from you whether you think there's any obligation on the patient or the patient's champion to kind of get in there and give them hell to make sure you get what you need.
Absolutely. You really do have to, get in there and really ask a lot of questions. And any services that I've received or am able to receive on behalf of Nick, anything I can get, I take. And that's just the long and the short of it. And you learn that. 5 years ago when we started our journey, and people said, now you're the caregiver, you must, be careful and take care of yourself. And I thought, I'm just fine. There's nothing wrong with me. I can do this, But I can tell you 5 years later, like I said, anything they offer me, I take, and we use it.
What do you know now you didn't know then?
Oh, gosh. That's a really hard question. That really is.
Well, let's start with this. What gets you further when you're trying to get care for Nick? Honey or vinegar?
Oh, honey, absolutely.
Really?
Yeah. No, actually, as far as the services go, I cannot complain. They've been excellent. CCAC has been there right from the beginning, introducing us to the Adult Day program, like I said, and then supportive housing where we live now, and the long-term care. I have no complaints at all. I'm very impressed with our long-term care facility.
Mary Ellen, how about you? Do you find you get, when you need things, do you find you get further with honey or with vinegar?
Oh, absolutely with honey, yes.
Okay,
This
you
has
two are
been-
just complete anomalies from everything else I've heard.
Well, this has been a 25-year journey for me. I have MS, and it started quite gradually, and I progressed through all the stages, and the use of a cane, 2 canes, and finally a walker. And then when my one leg would no longer, my foot would no longer touch the ground and I couldn't stand, then it was imperative that I was advanced into a wheelchair. It cost me my marriage 40 years, and that was a big hurdle. And going into, mind you, I live in an apartment, but it's adapted for disability, and I'm very comfortable. I live in a nice community in Chelsea Park, and the CCAC and ParaMed have all part. I mean, the major reason why I'm still able to maintain my apartment with the help of the Cheshire people, and I can't say enough about the care that they are able to give.
Can I ask how old you are today?
Pardon?
Can I ask how old you are today?
I'll be 73 in August.
73 in August. So you have been dealing with this since your late 40s.
Yes.
Tough
I think
road.
I was diagnosed finally at 50.
I bet you're sick of it.
I am. There's no alternative. If they will ever find a cure, I think that it's probably a collection of many things as they've gone through the different stages of research to find a cure. It's not that simple.
Sue, we have two very strong women here who have managed to find their way through their healthcare interactions and get the help that they need, and their reviews this morning are pretty good on their interactions with the healthcare system. But I want to know, for those who are less proactive and less able to advocate for themselves and not as strong as these two women, how do you empower people to get the services or the help that they need?
Well, I think to start with, it is truly about positioning the relationship, or because healthcare is all about potentially a healthcare team, but the healthcare team usually is one person at a time, with usually one person and or their champion. And if they don't have a champion, the expectation is that that interaction is one that is respectful and actually asks the right questions or spends the right time to be able to understand what it is that person needs. And so it is about structuring our system so that relationship, whether in a hospital emergency room or in somebody's home, that relationship can happen in a very open way. And so I think there's onuses on both sides. One is on the side of the patient or the client to actually speak up, but really the caregiver needs to be open and listening.
Paul.
Yeah, I don't think that we are really good at empowering at all the people in the system yet. And we use this word system, and everybody talks about, well, it's not a system, it's really a fragmented set of services. I think that was certainly one of the intentions behind the establishment of LHINs, was to concentrate a little bit more on the continuum of care. I mean, I'm struck by Frida, your comments on the care you were providing your husband in the last little while, where you were going from hospital emergency room to hospital admission to a tertiary care hospital, community hospital, back into the long-term care. I mean, that was a lot of transitioning during that period, and maybe for somebody who has some experience with this over the last 5 years that you've had, you are perhaps a little bit better able to navigate that than you might have been 5 years ago, because you've learned a lot about that. And I think that's where our system has to improve, is not rely on that, on that extreme of learning to happen, that somehow we have ways of ensuring that everybody understands that continuum, that when Frida, when her husband comes into the hospital, that there are appropriate ways of understanding not only what he needs, but what has happened, what's occurred before, what comes afterwards, and to be very concerned about that and be able to follow up and know what's going on. And I don't think that's a part of our culture yet in healthcare.
Ladies and gentlemen, I want to give you now an opportunity in our remaining moments of this session to ask whatever questions you may have to our panelists here today. So put your hand up, and if anybody, don't sod Rafi me here, and everybody just tuck and turtle. If anybody's got a question, we got one right here. We have a brave Canadian prepared to start things off. All right, stand by. Thank you.
Yeah, surely, Lisa. Just a comment as much as a question. I think the evidence that we are hearing about and participating in and witnessing is similar to what happened with this panel. The pitcher of water and water glasses didn't appear until somebody actually needed one, and then had to be brought out in the middle of the presentation. It's the lack of anticipation and provision for what might be needed by the client.
That's a fascinating point, actually. Let's give it some applause. Okay, who's next? Who's next? Yes, right here, please. Yes, sir.
I used to teach communications at university, and one of the exercises I had my students go through was trying to understand the difference between connotation and denotation. And I've heard people talking, using different words up here to talk about the people in the system. Sometimes you're saying client, sometimes you're saying patient. It sort of flips back and forth. And I'd just like to have a sense, anybody on the panel like to respond to that. What's the connotation? What's the denotation? What's the implications of how you see that person who's coming in looking for care? Is it a client? Is it a patient? What does it mean to you?
Let's start with our healthcare folks. Paul, do you want to take on that one first?
This is an awkward piece, actually, because it's been a conversation in healthcare for some time. For me, I think it's important to think about, Saad said it earlier about this is a person, this is an individual. And these words, client, patient, you're kind of labeling a little bit, and that gives you now a framework that you start to think about that individual through. And I'm not sure that's terribly helpful. But the client, patient, consumer, this has been an ongoing discussion in healthcare for some time, and certain people react to those words in different ways.
Frida, let me just get you on that. I'm over here. Sorry, I just sat for a second. When you go and have an interaction with a hospital or a long-term care facility, how do you want to be thought of? Client? Patient? Advocate? Wife? Human? What is it?
Probably advocate, I would think, in our case, because of Nick not being able to verbally speak for himself. So probably, yeah, an advocate.
Client doesn't do it for you?
No.
Because
I think wife would be would fit too.
Mary Ellen, what fits for you?
I guess that I felt like a patient for so long that to be called a client is not a lot different. And to me, in my particular case, because it's as though I'm buying a service in which I am in an instant, for instance. So it doesn't matter that much to me,
Got it. Sue, how about you?
honestly.
I actually don't have a suggestion for the actual words, but I think it's about, we often think of patients in particular. A lot of my background is in hospitals, so you think of patients, and typically we've done for patients, and we learn to do for patients. So I think it's about moving to doing with. This is a partnership, doing with. Whatever the word is that we want to use, it's that sense of doing with.
Do we know whether patients want to be referred to as patients, or given that they are, in some respects, paying for the services they're getting, do they prefer a more kind of client-provider relationship?
I'm not sure we've asked that question.
Never thought about it.
Okay, we got one here.
So I wanted to take you back to your earlier question around the opportunities at a systemic level about patient-based experience, client-based experience, or person-based experience. And I had the privilege of attending a conference that the LHIN organized in January, a 2-day session where Lynn Mayer and others were able to share some of the great work that's happening around the world, really, and some of the leading edge pieces. And I'm just wondering if Sue or Paul, either of you, you might have some tools and tips that you can share about, and Sue maybe in particular, around has any of that work taken hold? Because of course you can run seminars, you can run sessions, we can do that within each of our organizations, etc. But the piece of it is, does it actually take hold at the frontline level? Does it make an impact on that day-to-day interaction with the people that we care with and for? And I'm wondering if, Sue, if you have any insight into any of the tools or tips that were learned from that, and how, if at all, they might be having an impact across the Southwest?
Let's find out. Sue, go ahead.
Sure, thanks, Sandra. Absolutely. It's a long journey, I will say, that we're on, but to date, we've really picked up on the tool of having in-depth interviews with those people who have had care, some interaction with the healthcare system. Predominantly, we're looking at people that were transitioning from hospital to home with very robust service plans to get them to have the opportunity to stay in their own home. So we actually go in, we take a communications person who is much better than some, for instance, myself at asking open-ended questions, and really we record those interviews and understand the trends and actually use that information to help us improve that experience for the next person that goes down that journey. And so, for example, we know from those interviews that people really enjoy the opportunity to be able to go home and to be able to make any life-altering types of decisions around accommodation from their own home. We also know that those first few days when they transition, that it's tough. There's a lot of people and it's a big transition. And so we've gone back and actually learned that we need to space out how many professionals are in your house at any one point in time or in one particular day. So we've really learned from that and are really helping that situation for those people who are coming home. So I think we've got further to go, but that's been our journey so far, to really embed the client story into our work.
Right here, please.
I have a number of points I'd like to just touch on. Number one is I'm hearing, and I have personal experiences, that healthcare nowadays is much more about a technical experience than a personal experience. The people that are providing care for me or for my mother are very good at doing the technical healing, the sickness care, but they're not very much able to deal with the emotional side or the cultural side. Because I'm in Canada, very few people really understand the cultural difference among the different ethnic groups in Canada. In the Southwest particularly, it's very much predominantly Anglo-Saxon still. Everybody's white. Look around the room. The second,
Can I just follow up on that? You're obviously of Asian heritage, so what's the cultural difference that you would like to see reflected in your healthcare system?
the understanding of the role the family plays and understanding how the family members interact within that culture, as well as the difficulty from certain cultures in terms of actually asking for help. It's very difficult for an Asian family to say, I need help, because the culture is that you need to be self-sufficient. You're not to bother other people. It's only within the family. It's a bit like your skeleton in a closet. Illness is not perceived necessarily as something that you talk about. There's still a lot of stigma surrounding a lot of illness, particularly mental health illness.
And healthcare providers should be aware that that's something they'll have to deal with. Okay, make one more point if you would, please.
In terms of the funding system, I'm hearing this morning about the procedure-based funding and so on. That doesn't speak to me to what sounds like is needed, which is time. The care providers need time to actually have that relationship with the person. So when you're looking at trying to be efficient and cost-effective and all those things, how does this new funding system account for the need for the provider to spend more time with people?
Okay. Who wants that? Paul, Sue, which one?
I'm not sure that it really does.
You got some applause there, Amy. They like that one. Okay.
I'm not sure that it really does deal with that. I think as providers and leaders in the system, I think we have to deal with that. There's we could go on throwing dollars into the healthcare system, but I think there's some evidence to suggest a lot of what we do is wasted effort, wasted time. And where we need to change our focus now is how do we actually release that time doing things that we perhaps ought not to be doing or that don't really add a whole lot of value, and so that time can be spent doing the things we're talking about here this morning, about enhancing the patient experience, about doing that through creating more time for caregivers to be able to speak and then be sensitive to patients' concerns, families' concerns, and creating that opportunity. I think that there's not a lot of financial incentive sort of driven to that point, but I do believe that what the funding system is focusing us on is the need to find out where we're wasting time, where we're wasting energy, than things that don't matter. And the best people that can tell you that are the people who actually do the work. They've worked around these problems for years. They know how to fix them. Sometimes I'll speak for ourselves, myself and our own organization. Our system hasn't created the space for them to do that work, to be creative, to understand needs, to put in improvements that they know are going to make a difference. So we need to now spend a lot of time doing that, helping people to understand the processes they work through, eliminate things that don't matter, so that they can create the time to do the very things we're talking about. It's possible.
Okay, part of my job is to keep you guys on schedule, so we've got time for one more question, and it's you.
Great. One of the concepts that I was recently introduced to by a member of our quality advisory group was the notion of always behaviors. And a lot of what I'm hearing you talk about are those simple things that if people do, introduce themselves, remember to wash their hands. Is there an opportunity for organizations to look at those always behaviors that would provide for a better experience for the individual?
I think the answer to that is yes. There's lots of things that we can expect from a performance point of view or from an actual behavior point of view, and I do believe that organizations can certainly go down that road. My only caution with that would be is that we know the emotion is really important, and so if we script care to the point where, you know, you always say the same thing at the beginning and the same thing at the end of a conversation, it won't build that relationship. And so yes, I think from a behavior expectation, but I wouldn't want us to go down the point to actually script our actual caregivers in their work with people, because I think that takes away that important personality that helps us build relationships.
Paul, go ahead.
Yeah, I don't disagree with Sue, but I would have a slight more emphasis on not necessarily the scripting, but again, bringing that evidence-based approach, that method that says these are the steps that we need to consistently put in place and audit those things to make sure they're happening. Because we have a lot of good intention in healthcare. We're awash in great intentions about doing things. But if we don't have systems and processes that put those things in place to the point of saying this is the way we intend to have a relationship, that then we can monitor that, we can audit that, we can see if it's happening. People in healthcare, I think, come to it for the right reasons. I think they recognize it is a noble profession. It's a noble business to be in. And they have the intention to do well and build that relationship. What we need to ensure is that that is consistent, that no matter who comes in contact with the system, they can expect that that relationship will be built. They can expect that there are certain elements of that relationship that are actually being driven and being followed and monitored in the organization. I think that's how we will make these changes happen more rapidly.
Paul and Sue, I want to thank you for participating in the panel and sharing your professional experiences with us. And I know this audience wants to join me in particular in thanking Frida and Mary Ellen for being so candid and available to understanding their experiences this morning and helping us all this morning. Thanks very much to all of you.